Okay, for this lecture, we're going to begin delving into using your toolbox. So we're just going to refresh some of the ideas that we've already talked about, and then we'll start looking at what to look at when we're interpreting mostly what's called a 6-second strip or a telemetry strip. So just to refresh, we know that the heart is a wonderful machine that likes to have automaticity, excitability, conductivity, and contractility. So it uses those four things to create an effective pumping mechanism. So it requires electricity to do that. It requires all of your cells to be healthy and normal. It requires the SA node to function properly. So all of that electricity and all of those pieces, those unique properties, evolve into the mechanical pumping system of the heart. So we have to have that electrical piece. All right, so we know that the pacemaker of the heart is going to be the SA node, and it's the sinoatrial. It's in the upper left there of that right atrium. And that electricity is going to start there and move throughout the right and left atrium down to the AV node, into the bundle of His, into the right and left bundle branches, into the Purkinje fibers. And again, what we're looking for, hopefully, is an inherent rate, since it's starting in the SA node, of 60 to 100. But we do know, again, if that SA node fails, the AV node can take over, and it has an inherent rate of about 40 to 60. Unfortunately, that's not going to be enough to maintain enough cardiac output. We're not going to be able to perfuse as effectively. We know that it's the sympathetic and the parasympathetic system that work together to speed up or slow down in response to structural changes and to stress, that have an effect on medications. We see our test taking tips over here on the right. I have seen questions that want to be like super impressive, I guess, and talk about sympathomimetic drugs. Well, those are just drugs that increase your heart rate and blood pressure. And then parasympathomimetic drugs are drugs that slow those things down. So don't let the big words scare you. I don't think that those words will be on NCLEX. Again, those are just, I have seen practice questions using those concepts. We're going to review our electrolytes here, but we know that when we have issues with calcium, potassium, and magnesium, you can have changes in the PQRST. So we see the top one there on the right-hand picture is the normal, and then we see changes with hypokalemia, hyperkalemia, and then changes with calcium as well. That's not something, again, that I would ask you about. What I would say is that you should know as a new nurse that if you have changes in those electrolytes, that you are at increased risk for some sort of dysrhythmia. Right? I'll be perfectly honest, that you see the hyperkalemia one that says the peaked T waves. All my students think every patient has tall peak T waves, and none of them have hyperkalemia, because you can set the sensitivity of the machine to make your PQRSs bigger or smaller. So my advice to you is to make sure you're reviewing your results reviews before you go talking about tall peaked T waves. Okay, some things that can happen with electrolytes. We're going to just look at calcium real quick. I see CDE, right, and CD. So it starts with calcium. That's why we start with the C. But when I'm looking at that, what I want you to understand is the big one is dysrhythmias. The big one is pulses. If you go and you feel a bounding pulse, you know you need further assessment. If you go and you feel diminished pulses on somebody who does not have PAD, you need further assessment. We know that cardiac arrest is a potential because of the electrolyte imbalances. And then you're going to try to get rid of it through excessive urination. That's more of a fluid and electrolytes question, not a cardiovascular question. Where calcium goes, hopefully you remember, magnesium must follow. So with hypermagnesium, everything must sit up, right? You're going to see shallow breathing, irritability, twitches, or seizures. With hypomagnesium, everything is sedated. It goes low, 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 and that's what increases your risk for your heart going into that dysrhythmia that's not on the test called Torsades de Pointe, which is just basically a twisty, turny VTAC. Potassium is probably the biggest question that you will see. You will 100% see it on my exam. Potassium is vital to the function of your heart and the conduction system. So with hyperkalemia, you'll see muscle cramps, urinary changes, respiratory distress, decreased contractility, which is just a bad way of saying you have a bad pump, ECG changes, and you can have changes in that PRI. Hypokalemia, thready, irregular pulses. We've already identified that weak and thready is deadly. Changes into your blood pressure, ECG changes, and shallow respirations. So notice that when you're looking through here, this just basically means you have a bad pump, and this basically means a dysrhythmia. This is a dysrhythmia, and this means you have a bad pump. So I look for those things that are consistent for those disease processes. So that electricity turns into the mechanical piece of it. And I know you folks are familiar with systole and diastole. You have atrial contraction, that's going to be your P wave, and you have ventricle contraction, that's going to be your QRS. If you are having issues and you don't have a P wave or your atrias are not functioning properly, worst case scenario, you lose that atrial kick. So you lose a little bit of stroke volume, so you diminish a little bit of the cardiac output. With diastole, if you have an ineffective relaxation of the heart, what it basically means is that you're going to lose a little bit of cardiac output, right? Because not all the blood can fill in there, or you can't relax all the way to get enough to fill. We'll look more into that when we are talking about cardiomyopathies, but this is the mechanical portion of the conduction system. And hopefully we remember that the right and left hearts should be synchronized. So when the atrias contract, they contract together, and when the ventricles contract, they contract together. I love these illustrations. They show you how quick everything happens, and it shows you how that electricity on the left turns into the mechanical, and then on the right you see actually the electricity that is starting from the SA node. It's about to happen here in just a second, and you see it initiating, and you see the development of the atrial contraction. There's the P wave, and then you see now on the right hand side that this client has a QRS, so that's ventricular contraction, and now ventricles are relaxing. That's everything that we hope to see when we talk about how electricity stimulates mechanical action. So we understand that electricity controls the mechanical pumping of the heart. We absolutely know that that is a true statement. You have to have that piece to make the pump work. Unfortunately, we do know that some medications that we give quite frequently can cause conduction delays, things that slow down electricity, things that cause bradycardias. Calcium channel blockers, lots of calcium channel blockers out there. It says specifically here, verapamil and diltiazem. Verapamil is an ACLS drug. You won't see it on my exam, but you may be exposed to it further in ACLS. Diltiazem we give all the time for AFib. Right? We don't assess an apical heart rate for diltiazem, but as a good nurse, you should understand that calcium channel blockers slow down electricity. Beta blockers, we absolutely know slow down your heart because we have to take an apical heart rate before we give it. Usually you're going to hold it if it's less than 60. But they also can delay electricity from the P to the QRS. So we have a delay in electricity in what's called the PRI, the PR interval. and that's going to cause a heart block. And that's exactly what we're seeing here on the right-hand side. We see that I have more P's than QRS's, and then I'll try to illustrate this. You see how this distance between this P, and this QRS is different than this P and this QRS. So typically this would be a second degree type 1 type of heart block. A heart block is going to be a different dysrhythmia that we know, but if I saw that, the first place that I would go is look at my electrolytes and look at my MAR. In the upper left-hand side, we have an example of a tachyarrhythmia called SVT. I know it's SVT because the QRSs are tall and skinny. I can't necessarily see a P wave, and that's because it's a machine. And it's trying to record everything that's happening in 6 seconds, and it can't fit that P in there. But we will say, when we talk about atrial dysrhythmias, that we know if it's tall and skinny, and it doesn't have to be tall, I just keep saying that because it's a bad habit. If it's skinny, if it's less than 0.12 seconds, that it's going to be in the atria. In the lower one, we see the heart rate 34, and we see a normal PRI, that they're the same distance apart, that nothing really changes there. So that's probably a sinus bradycardia. So I would go and look for a beta adrenergic medication for both of those. Beta blockers are great and they're terrible. We can have issues with hypertension, bradycardia, hypotension, or tachycardia. That's a lot. Okay. We have medications called a cardiac glycoside, and that's just our fancy way of saying digoxin. Right? Digoxin will indirectly slow down electricity. The bad part about that is that it will also cause toxicity. So for clients who are receiving digoxin, I want to make sure I'm assessing for heart blocks, for bradycardias, for seizures, blurred vision, nausea and vomiting. We are going to say, when we talk about pediatrics, the infants aren't telling us that they're seeing yellow halos. Most books will tell you that yellow halos are an early sign of digitoxicity. I've never had a client tell me that they've had yellow halos. But what I do see a lot is nausea and new vomiting. So if I know I've given a new dose of digoxin and I know that I can get dig toxic after the first dose, I know I should probably go look at their electrolytes, and then I probably need to get a dig level. In this illustration to the right, we can get dig toxic on the first dose. So we see in this top 6-second strip, it's moving pretty fast. So I got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. Our heart rate's between 150 and 160 in that top one. We give digoxin. We're probably doing the loading dose, giving a digoxin IV push. And then all of a sudden I have this period of asystole. Their heart right now is fibbing. If you know V-fib, you know what a fib is. The heart's not pumping. So I have about 4 seconds of no cardiac output. And if you keep putting those 4 seconds together, you end up in asystole. Okay, so that's the basic thing that we would start with. The big takeaway is that we need to evaluate your results reviews, right? Your electrolytes, and we need to review their medications to see if there are anything that we are causing. That is, again, such a huge, huge piece that you need to ask yourself every time you're doing an assessment. Did we cause this? Unfortunately, there are a lot of medications that cause problems with the conduction system and your rhythm. So this portion is what we're basically going to be called the toolbox, and we're going to go over the pieces of the PQRST and what they are and what they should be. It's going to be repetitive. I apologize in advance, but I need you to understand what is going on. So the first thing I want to look at is the P wave. This P wave should be upright always. I'm not going to get into what it means if it's upside down. You'll get into that more when you're taking your ECG courses. But it represents atrial contraction. So atrias are small, your P wave is small. The next thing is this PRI. So you're just going to measure from the beginning of the P to the beginning of the QRS. Now this client just happens to have a Q wave. Even if they don't have a Q wave, it's still called the QRS complex, right? So that should be less than 0.2 of a second. So that's the rule for your PRI. It's less than 0.2 of a second. That's not a lot of time, right? We'll look at that from a 6-second strips, and we'll call that the PRI should fit in one big box, because I can't ask you to measure 0.2 of a second, right? I know fully trained RNs that can't do that. The QRS complex, okay, that's going to be that Q wave, it's going to be the R, and it's going to be the S. And it's called the QRS complex regardless of whether or not there is a Q. So most of the time when I draw the QRS complex, I just draw a little V. It's either an upright V or an upside down V. Doesn't matter. We don't care which direction these go. And again, that's hard, but if you remember me saying when we're looking at a strip, you have to get used to only looking left to right. Up and down does not matter. The size of that QRS does not matter. We just have to have one because that means our ventricles are contracting. If I were to have a Q, it would look more something like this. So we have the Q here, R here, S here. This represents ventricular contraction. People that have a Q wave generally have a Q wave because they have some sort of previous myocardial history. Here it says an infarction. That could be the case. It could be a number of things. We should all have an R and an S. This ST segment, so now I'm looking at this S, it's come all the way to the end, and now it goes back up to what is called the isometric line, right, which means nothing is happening, and I'm looking at this ST segment. It should be about to baseline. It should come back up to baseline and kind of flatten out. This is an extremely nice example because it does exactly that. I promise you on a real tracing, it's not that pretty. But what is pretty is that if I'm going to give you something like ST elevation, their ST elevation isn't a whole lot. If I'm going to give it to you, it'll be noticeable, right? So that's the ST segment, and that's where we're going to look for a STEMI, an ST elevated myocardial infarction. The T wave represents ventricular relaxation. So right now we've talked about contraction, and now the T wave is relaxation. And we're going to say an inverted T wave or an upside down T wave just means that they either have a cardiac history or are having a cardiac issue. I just need to find out whether or not that T wave that is inverted is acute or chronic. But here's the deal. It does not affect your interpretation at all. The only thing that I'm going to look at for my interpretation is the P, QR, PRI, QT, and R to R. We'll talk about that again. That's part of our toolbox. So here's that whole PQRST complex. Depolarization, depolarization, repolarization. Or, let's see if it works, contraction, contraction, relaxation. This is atrial. This is a V, so it's ventricle. And this is the follow-up to the ventricular relaxation. Contraction, contraction, relaxation. The atria actually repolarize while the ventricles are contracting, but because it's such a small signal, the machine does not register it. So you're not missing anything if you're like, oh, where is the atrial repolarization? We don't look at it. We don't need to look at it because we know that it's happening during that QRS. And the QRS is the ventricles, so they're the most important thing. So making sure that those waves are present and they're doing what they're supposed to be doing. I'm going to measure the PRI. I'm going to measure this QT. And I'm going to measure the distance between one R to the next R. Again, that's part of your toolbox. So the first thing that we need to look at is that most of the time when we're interpreting a 12 lead, not 12 lead, when we're interpreting telemetry, that we're usually interpreting a 6-second strip. Well, how do you know if it's a 6-second strip? Well, a couple of ways. One, I can count 30 big boxes, and I'll show you a better example of what 30 big boxes means. This one down here, you can't really see them on. Two, I'm going to tell you, you're interpreting a 6-second strip. So it should not be a guessing game for you, right? The other way is that you can look, and it's some of these from the beginning to the end will have little tick marks. And usually they'll have little tick marks every 3 seconds. So this is that 3-second mark. Unfortunately, not all machines will have this. I know that the machines that we use when we go to print out a telemetry strip will actually print out about 10 seconds. And then we actually have to figure out where the 6 seconds is because we don't have those little tick marks. But what I do know is what I'm going to start with are these PQRS complexes, and I'm going to count them. For each atrial contraction, I should have a ventricular contraction. So when I do that, I notice I have 7 of those. And because I'm looking at a 6-second strip, I know that if I multiply that 7 by 10, 60 divided by 10, that's how we get that number. That's how we get the heart rate, because it's a heart rate per minute, will give me roughly somewhere, for this person, between 70 and 80 beats per minute. Why is it between 70 and 80? Because you have extra time here and a little extra time there. Right? Well, I guess there's not a whole lot extra time because that's the T, but you get the idea, right? So this is probably really like 73-ish heart rate. It would be impossible for me to ask you to do that. I'm going to show you later on a better way to do it, but it's a more ACLS type of thing to do. If you can tell me that that heart rate is about 70, you're doing exactly what you're supposed to be doing. Okay, so again, repetition. Here I see an example of everything that I need you to look for. P, QRS, this person does not have a Q, but it's still called the QRS complex. T. And if I were to look at this PQRST, it looks exactly like this PQRST. I'm going to then measure my PRI. Okay. I'm going to measure my QT, and then I'm going to measure my R to Rs. So I'm going to break this down for us. When I said my PRI should fit within one big box, this, what I'm drawing on the screen there, is one big box. That's 0.2 of a second. Now, most of our machines also break it down into smaller sections, and there's 5 of them. So 20 divided by 5 is 0.04. So that's how we know that our measurements are correct when we're looking at tall and skinny. So if I look at this, and I measure from the beginning of my P to the beginning of my QRS complex, that fits inside one big box. Can't ask you to measure 0.20, but what I can ask you to do is say, that fits in that big box, and if I'm going to give you something that doesn't fit in the big box, it would be noticeable.
I need to make sure that the QRSs are skinny. Again, I don't care about up or down. If the QRS went down this way, I don't care. It doesn't matter. It's just how you're looking at the heart. And then I need to make sure that the ventricles are relaxing. But again, the T wave does not affect my interpretation at all. I'm going to measure that QT interval. So at the beginning of here to the end of the T wave. And I said it should fit within half of this R to R. And if you look, that's 1, 2 boxes. And over here is 1, 2. So it's about half of your R to R. So we're going to review those concepts in depth again. Okay, so we'll move on. This is the one where I say you may see it broken down even further. But if you look at this, a couple of things that I can tell. It's a 6-second strip. I've got 30 big boxes, and it's broken down into the smaller boxes. I see I have a P for every QRS. This client has a Q wave. It's this negative deflection right after the P wave. When I say negative, I mean the downward deflection. So that little piece right there. So I know whoever this client is, they have a cardiac history. I know that the PRI fits roughly within one big box. I know my QRSs are skinny, and I know my T waves are upright, and the ST segment returns to this isometric line. So I would just count, and when I count, I notice that it's about 80. It's 80-ish, we're going to say, because that's good enough for basic nursing. If you want to be super high speed, you can take 300 divided by the number of big boxes, right, in between the R to R's. So you see it's about 1, 2, 3, and we're giving a little bit of credit there. It's about 3.6 big boxes, and that will actually give you a heart rate of about 83. That's such an ICU thing to do. So all my ICU nurses enjoy doing that. For us in basic nursing, it's between 80 and 90. Okay, so the toolbox. I know 100% that if you don't use your toolbox, you're not going to get the question correctly. So we want to, again, start from the beginning. Repetition is the only difference between me and you. I've been doing this a long time. So I'm going to start measuring my R to R's. Your R to R's should be the same in any sinus rhythm. They should be consistent, and that's going to be our keyword. We're going to keep saying consistent over and over. I should have a P wave. That P wave hopefully is upright. That's what we're going to look for. And then I'm going to measure that PRI. That PRI should be less than 0.20, or it should fit inside one big box. I'm going to make sure that that QRS complex is somewhere between 6.06, and 12. I will often say 6 to 12. I'm implying that it's 0.06 to 0.12. And they are similar, right? Nothing comes early, because if it comes early, it's probably a premature something. We're going to look at that ST segment to make sure that it returns to that isometric line and it's not above the isometric line. Anything above or below usually is indicative of ischemia or injury. If it's above, you know that that means infarction. I'm going to look at the T wave. It doesn't affect my interpretation, but I want to make sure that it's upright. If it's not upright, the only thing that I need to ask myself is it new? Is that T wave inversion new, or is it acute? Because T wave inversion, since it's the I word again, it means ischemia. That's what inversion means for T wave. But I don't know. Is it that they have a history of heart failure? If they have a history of heart failure, I could expect T wave inversion. And then I'm going to measure that QT interval. We said the QT interval again should be half of your R to R. Why is the QT interval so important?
So I'm going to try to illustrate this for you, and you guys got to forgive my terrible drawing. I'm doing this with a mouse. So I have P, I have Q, R, S, and I have T. That's how it should be, right? It's about half of your R to R. So when your next one, P, Q, R, S, comes up, this distance should fit roughly half of this, the R to R. If I have a prolonged, an elongated QT interval, it looks something like this. That's going to lead to a set of problems because your heart still wants to beat in a rhythmic pattern. So if I expected this next P wave to happen right here, and you have prolonged QT, that means your atrias are going to contract at the same time your ventricles are relaxing. There's a little space in here. You have, it's called the absolute or relative, so two different things, but it's the same terminology, refractory period, which is a fancy way of saying electricity will do something or electricity will not do anything. If it's absolute, no matter how much stimulus you give it, nothing's going to cause that heart to do anything weird. If that P wave lands in that relative refractory period, you're going to go into VFib, VTach, and that's bad. A lot of medications can prolong that QT interval, so just make sure that you're looking at it. And if it looks like it's getting progressively longer, that you start examining their medications. There's too many to list. There's too many to test you over. It's just, the answer is, look at the MAR, look at their electrolytes. That's a great answer for anything dysrhythmia. So we have said that the P wave, that first positive deflection, represents depolarization. The PRI is the time that it takes for that impulse to travel from the SA node to the AV node, and that should be less than 0.2 of a second. That's all the PR interval is. If you have issues in things that slow down electricity, I encourage you, again, to look at the MAR and look at the electrolytes. It's usually something we did. Not all the time, but 80% of the time. For basic nursing, it's close enough. So, here it is again. I'm measuring from the beginning of the P to the beginning of the QRS. PRI. I'm looking at the measurement from 1R, and just, it's the QRS complex, it's the top of it, to the next one. And what I want to look for is consistency. Each R to R, because your heart wants to beat in a rhythmic pattern, should be the same. Okay? So now we've taken care of the P, we've taken care of the PRI, we've looked at the R to R. Q waves, we've said that simply means there's some sort of cardiac history. If they don't have a Q wave, it's still called the QRS complex. The R wave will be that first deflection after the P or after the Q, depending on if you have one. It doesn't matter if it goes up or down. It's just one part of the QRS complex. So this alone, that single line, is the R, followed by the S. What you need to understand about that is that it should be skinny. I don't care if it's as big as the first one or as small as the second one, because again, we don't care about up or down, we just care about left to right. That whole thing together represents ventricular, because it makes a V, contraction. And it is 0.06 to 0.12.
So here we can see that we're kind of measuring that. And as long as you can tell me that, hey, that is, and I'm going to say tall and skinny, it's my bad habit. As long as it's tall and skinny, you're okay. You could have changes in the QRS, and I'm not going to ask you about these because, again, this is more ACLS-ish. But there are things out there called bundle branch blocks. We've already looked at ST elevation. So a bundle branch block basically looks like bunny ears. You've probably seen this, right? It just means that there's a delay in conduction, right, in those bundle branches. Versus ST elevation, which looks like a tombstone. Right? You see how that ST segment is way above that isometric line. If it's acute, it's an emergency. Right? In ST elevation is always acute. So there's not a whole lot of thinking that we have to do, right? If you have this kind of change, or, now blow your mind here, normally we would have this. If you have a cardiomyopathy, you can have, draw it down here, a chronically widened QRS. How do you know it's a chronic versus acute? You go back and you look at their 12 lead when they came in. Are they symptomatic or are they not symptomatic? Doesn't matter, because you know if you have a bad pump, there's something slowing stuff down, so it takes longer for your ventricles to fully contract. So just ask yourself, is it acute or is it chronic? And then if you put a bunch of those wide and bizarre QRSs together at a really fast rate, you have VTAC. Right? T-wave. Do we really care? Absolutely not. It does not affect my interpretation. Again, look at the MAR, look at the electrolytes. You're probably not going to find anything different. We talk about the T-wave because of the ST segment, and that's just the honest truth. So down at the bottom, I see that one is an example of ST elevation. You see how that S does not come back to baseline, so that whole ST segment is above the isometric line. That T-wave is still upright. In the second one, it says ST segment depression. You see how it goes below, but it never comes back to that isometric line. It's not elevated, so it's probably chronic. You have some sort of history of heart disease. And then you have the T-wave. And then the next one, you have T-wave inversion. So everything comes down, and instead of being an upright wave, that T-wave is inverted, and that simply means ischemia, either acute or more likely chronic, because they have some sort of cardiomyopathy. Okay. Let's look at this. So I've marked off what our 6-second strip is here by the big arrow, and I want you to understand that this is the exact same client. The only thing that is different here is, my pen will come up. This is lead 6, this is lead 2, and I can't read B5, right? So it's the same heartbeat. This one I have P, I have tall and skinny QRS, and then I have an upright T. I'm looking at the heart from one view, right? If I'm standing here, the heart rate looks much different than if I'm standing over here. It's all about perspective. I have a P for every QRS. So let's see, I have 1, 2, 3, 4, 5, 6, 7. My heart rate is roughly probably like 78, somewhere in there. It's between 70 and 80, because here is my 6-second strip. This is the exact same thing from a different view. P, QRS, how it comes back to the isometric line, and then what's that T-wave doing? It's inverted. Do we care? Nope. Does not affect my interpretation, right? The next one, we move on. I still see P, I still see Q, RS, and then another inverted T wave. I know just by assessing this in the morning that when I go into the room, my client has an issue with the cardiovascular system. That's all it's saying. So that ST segment then becomes really vital to what we assess. And it means very different things. Okay? We know that we're working our way from ventricular depolarization to repolarization of the ventricles. And so we have the QRS, and then right after that is that ST segment. Your ventricles are trying to relax. Okay? When it's elevated, that's very bad. That's very acute. That is a ST, elevated myocardial infarction. If it's depressed, it depends. Is it new or is it chronic? Most of the time, I would say ST depression is probably chronic. They have a bad pump, they have heart failure, they have a previous MI, whatever it may be. Now their pump just doesn't work quite as well as it used to. Okay, QT interval, we've kind of looked at that. We see the big circle. We're measuring from the beginning of the Q to the end of our T. We said it should represent or should be about half your R to R. And if not, then you're at risk for a lethal dysrhythmia. If you know that, you are going to do really well. Okay. You put that all together, and what do you have? The toolbox. You are then ready to start actual interpretation of the entire 6-second strip, 12 lead, whatever it may be. We can look at it and start that interpretation process. So that is your toolbox. I know it seems like a lot, but here are your big takeaways. Consistent R to R's, P for every QRS, small PRI, small QRS, tall and skinny, right? And a QT that's half your R to R. It's like 5 to 6 things that you actually have to know to be able to start using the toolbox effectively. All right, so when we get into the next piece of this, we're going to start looking at those sinus rhythms.